Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot. And today, I'm delighted to be joined by Dr. Chadi Nabhan. He is the Chief Medical Officer at Aptitude Health and a medical oncologist. Chadi, thanks for joining me today.
Thank you, Nick, for having me.
So I specifically reached out to you because I had the opportunity to read an article that you penned with your colleague, Benjamin Mazer, called Strengthening the Medical Error Mean Pool. For the benefit of the listeners, maybe you could just give us a quick vignette of what it is, what this is all about, and then we can dig in.
So really, our goal of this paper was to try to dig deep and critically into the statistics of medical errors. We have noted that whenever you ask somebody about the frequency of medical errors in the US, the first thing that comes to mind is hundreds of thousands of people die in US hospitals from medical errors. And not uncommonly, folks would say it's the third common cause of death in the US. And we've seen that, Ben and I, on social media, on TV, again, when so we wanted to figure out how truthful are these statistics. Let's try to really dig into the data and try to understand the facts. Neither Ben or I dispute that medical errors do exist. We are in full support of trying to improve on current processes. We believe we can always do better. But that by itself should not imply that we accept the current inflated and exaggerated statistics as facts or science. I think it is okay to try to understand where these numbers came from so we can see if they are true or false. So that's what we try to take on this project, because we frankly got sick and tired of hearing the same thing. We're killing people in the hospital. The third common cause of death in the US is, our medical errors.
And I've got to be honest, I'm pretty sure that I would have been complicit in using those numbers and just making an assumption that, gosh, it's the third leading cause. And, we're talking hundreds of thousands of errors. And as you've clearly done in the piece, you've dug into that a little bit. So share a little bit about your sort of process and some of the thinking as you started to dig into these numbers to understand where they came from and, the actual realities behind it.
Yeah, the first time, if you go back in history, the Institute of Medicine report that came in the late 90s and suggested that about 90,000 plus patients in the US die of medical errors. That statistic was never really fact-checked. And in fact, there was an editorial that came out in JAMA after the Institute of Medicine report that debunked some of these statistics, debunked the methodology of how these statistics came out. But somehow the debunking of these stats really doesn't make headlines. It's not enough doesn't make it to the media attention where the media can grab on these headlines. And it seemed that between that report until recently, anytime there's a patient safety talk or a quality improvement talk, the first couple of slides are always showing how many people are dying in US hospitals from medical errors. And then in 2013 and 2016, two additional papers came out, one of them in BMJ, and these two papers even exaggerated the numbers further. And the first one that came out in 2013 suggested that over 400,000 patients in US hospitals are dying from medical errors. And the second one in 2016 suggested that over 260,000 patients are dying in U.S. hospitals from medical errors, making it the third common cause of death in the U.S. And it seemed that, that the media just, take these numbers for granted. Nobody looks into where these numbers came from. What are the statistics? To give you context, Nick, in the U.S., between 600 to 750,000 patients, unfortunately, die in U.S. hospitals. So if we accept that 440,000 patients are dying of medical errors, then we are saying that over 60% of hospital deaths in the U.S. are from medical errors. So would you even go to a hospital if you knew that 60% chance you could have a medical error and that medical error could lead to death? So we need to just think a little bit, critically about these numbers, where these numbers came from, and do they first, honestly, just pass the smell test? I mean, I did my own survey by people asking people around that have nothing to do with medicine. I say, do you really believe these numbers? And it's like, no, there's no way. I mean, this really doesn't make any sense. And then we wanted to look into the science behind it and fact check it. So the first thing is we need to decide when a medical error happens, is that medical error preventable or not preventable? Number two, if a medical error happens that is preventable or not preventable, and the patient outcome is unfortunate, can we really link that medical error to that unfortunate outcome? These are two issues that are not trivial, and they're very important. I can give you a lot of vignettes on this, but I'll give you a very simple, quick vignette just for your audience and listeners to put that into context. Let's say a patient gets into the hospital because has dizziness and confusion, and an MRI of the brain is done, and they found a tumor, a brain mass, and the patient needs to have a biopsy of that brain mass. The clinical team makes a decision that we are not going to put this patient on DVT prophylaxis, deep venous thrombosis prophylaxis, because we're afraid maybe there could be a bleed in a fresh tumor, whatever it is. We'll just do compression stockings and whatever it is. That was a clinical decision that was made, discussed with the patient. Unfortunately, this patient developed a pulmonary embolus. Was a medical error committed? Was that clinical decision based on the actual clinical scenario? If the outcome of the patient was unfavorable, was it because of this? Would really the overall outcome have changed? The same exact patient, let's say you put them on DVT prophylaxis and they get a bleed in the tumor. Was a medical error committed? There are trade-offs in medicine. We have to make decisions every day, and these are very, very difficult decisions. And I think when we talk about medical errors, the first thing is to ask ourselves, are these medical errors preventable? Are they errors, first of all? Could they have been prevented? And did they lead to the actual adverse outcome of the patient? Causation versus association.
And so I want to pick on that specifically, because the example you give is a fantastic principle that underlies this. Essentially, in the two examples that you gave of the same case, give anticoagulation, don't give coagulation. In both instances, the result could have been ultimately a sad death in the patient as a result of either the DVT or a bleed. And what you're essentially capturing is the struggle that we as clinicians and patients have on a daily basis, which is there is no binary choice in this. There are risks, and essentially we have to weigh up those risks and make the best possible decision that we can in the case of the patient. And ultimately, what you're saying is that as part of this, the dive into the numbers suggests that in part, some of the numbers that they've included typically include those decisions where they're not preventable outcomes as a result of the medical treatment that took place.
They didn't even look at that. That's not even. This was not even looked at. When you look at the papers that they actually analyzed that looked at medical errors, they were able to find very handful of cases that were labeled as medical errors. And I would direct your listeners to an editorial that was published by the BMJ editors in chief that debunked the paper by Macquarie et al. That looked at medical errors. And we cite that paper in our manuscript that just came out. They really beautifully have a table in that paper that looked at every single study that looked at medical errors. And essentially what you'll find, Nick, is that every single study had very handful of cases, 12, 9 cases, 12 cases, 14 cases of medical errors. And somehow they applied an exponential methodology that they extrapolated from these 12 or 14 cases. If we apply some arbitrary number, then we get to 200 and 400,000 figure. These papers were never designed to look at the incidence of medical errors on a population basis. There was no actual methodology to extrapolate these numbers into the entire hospitalized patients. So they took a handful of cases that were found, that they were labeled as medical errors. They were not reviewed, by the way, to look if they were preventable or not preventable and if they were directly linked to the adverse patient outcome. And they applied an arbitrary magnifying formula where they said, because we found this, then we think if we apply this on all patients, we get 200,000 plus or 400,000 plus. So it's really, the methodology was not sound. It didn't really actually exist. And the BMJ editors-in-chief, they argued for this. They said, let's try to look at the science and let's try to understand what the methodology was. And there was none. There was no methodology.
I think the interesting additional point here worth noting is that initial article is cited as one of the top 6 most read articles on the site, and yet the piece that you're referencing that did a detailed critique and essentially debunked the data has only been cited 16 times in
yeah.
So there's a mismatch, and part of that gets to this whole concept that you've essentially talked about, this meme pool and the prevalence that we have. And it reminds me a lot of something that I heard repeatedly as I've done sort of on-screen work and interacting with the press. And what they say is, if it bleeds, it leads.
Yeah.
And this is the same here. If there's not, people don't have an interest in, normal, steady, life was perfect, there was nothing going on. That's not news, as it were, and that doesn't essentially spread in the way that these other things do.
And the more you keep repeating the same thing, the more it becomes engraved in the minds of people. And we call, Ben and I in the paper, we mentioned that the anchor point becomes very difficult to migrate from. It becomes really very difficult to move from your anchor point because you've established this as a fact. So
even though it's not, right?
Even though it cannot stand the test of rigor. And I think we need to all agree that we are all in this together, because I will always say we are either current patients, previous patients, or future patients. We
Absolutely.
are unfortunately going to be in a hospital one day and entering the healthcare system. There's no way around it. We are going to be, unfortunately, in a hospital. So we need the hospitals to be safe. We need medical errors to be eliminated if we can, although I don't think you can get to zero. But all of that is not an excuse to exaggerate the numbers. Now, exaggerating the numbers get you headlines, get you on TV shows. I cannot tell you how many times I've listened to a talk given by folks at a hospital where the first 2 slides, the presenter is saying, every single day, think of a Boeing 777 crashing. This is what's happening in U.S. hospitals every single day. And people just this is just sensationalizing the truth.
And for those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm just delighted to be talking to Dr. Chadi Nabhan, who is one of the co-authors of the Strengthening the Medical Error Meme Pool. We're just talking about these fantastic statistics. And before anybody throws any flames at me, if you've seen at least one of my presentations, I know I have included that, and I'm shamed to admit it, but I'm going to admit it. And for all the reasons that I think you describe and I think are important to sort of explore a little bit, because you dig into this, because there is some perspective that says medical errors are bad. I think we all agree on that, and we want to drive them out. We'd love to reach the Six Sigma ranking that's the case in the airline industry. Driving it out completely would be a dream possibility, but using this to advance improvements is actually counterproductive. And you talk specifically to the downside of this whole discussion. So tell us a little bit about that, because you dug into those details.
Yeah, I mean, and to level set, obviously, medical decisions could be complex, Nick. We all know that. It's not easy. The human body is not easy. Diseases are complex. I gave you a vignette just as an example where hopefully your listeners could appreciate the complexity of sometimes making decisions that seems too easy, and realize that sometimes if an adverse outcome occurs, did really an error happen versus we just exercised our best clinical judgment. But think of it from the fact that you could make an argument. Okay, well, so medical errors are exaggerated. What's the big deal as long as they help into driving patient safety movements? Well, there is a downside. The people will lose faith in the system, in the healthcare system. That is a big downside, because if you lose your faith in the healthcare system, you may not seek medical attention where medical attention is needed or indicated. That is a problem. I think we know from when you look at some of the litigation and medical malpractice law firms, where this is something they would say, medical errors are the third leading cause of death in the United States of America. Call us, because this could have been prevented. All of a sudden, this creates this whole new career and a new issue that is going on. That's really not good for our society and for our patients and for our system. And some folks could politicize this. You could politicize this in a campaign. Guess what? If you look, and Ben and I, by the way, are writing an editorial right now that hopefully should come in the press in the next couple of weeks. But I'm not talking politics here. I'm staying very, very neutral. But the National Rifle Association, the NRA, did have an ad a couple of weeks ago, which I can forward to you after this conversation. In that ad, what they said, that medical errors are leading to 1,000 more deaths than gun violence. All of a sudden now, you took statistic that is incorrect and you use it for a political campaign. So whatever you stand in terms of gun violence or whatever it is, we can all agree that this is not the proper way to use a statistic that is incorrect. So we can see a lot of downside to this. And all what Ben and I were asking for folks is to pause, step back a little bit, and let's look at the data, the statistics, and the science, and see if we can reach an agreement that they are exaggerated.
So I think that's a great point. And, again, I think you've been clear. I'll be clear, irrespective of what side of the aisle the discussion you fall upon, the most important thing is to have a reasoned discussion based on facts and science, I think is what you're saying. And what I'd like to do in the remaining time is sort of talk a little bit about what you describe as the way forward. So how do we emerge from this? What are the responsibilities, and how do we as clinicians and patients and all the participants who ultimately are not pulling in different directions. I mean, I just don't believe that for the same reasons that you don't. We're all going to be a patient at some time or have been. How do we pull this in the right direction?
I think having an open dialogue and communication with each other, like what we are doing, with patients, with families, as well as with politicians and with TV figures and with journalists is really important. Trying to explain all of this is very critical, because I do think we can do better in terms of patient safety and what we are doing, improving processes. But again, we can do it the right way. I do think that part of the solution would be whenever something, an error is or a near miss actually occurs, going back and do what Ben and I call a chart autopsy is really essential to try to figure out how much of this truly led to whatever adverse outcome. Factor into that the patient's comorbidities, the other issues that the patient is dealing with, and try to have a very transparent way of saying, okay, we understand that an error occurred or could have occurred. It was a near miss, but we don't believe that this led to any problem that the patient had. And the BMJ editorial, by the way, I just referenced earlier, they give also another example. A patient comes in the hospital with sepsis, multi-organ failure in the ICU. Inadvertently, you started him on an antibiotic that patient was allergic to. Develops a rash, and obviously you stop the antibiotic, you start something else. A medical error occurred. Adverse event occurred with a rash or the allergy that the patient had. But I think we can all agree that somebody came in with sepsis, multi-organ failure. The outcome of that patient was not, frankly, affected by the adverse drug reaction that the patient had. So having this type of dialogue is going to be critical, and digging deep into each chart is going to be essential.
So, I think what you highlighted specifically, and for those that are not in the profession, they may not be aware, but this is already an integral part of the medical profession. We have root cause analysis, we have morbidity and mortality meetings, we have reviews, and the only thing that I would posit as a positive improvement or an incremental step, as I like to sort of think about it, is a less pejorative process sometimes. I think that's one of the challenges we have in the airline industry. The big flip for them in safety was to make it a no-fault analysis. And I don't know that we're as good at that in medicine, but we've got the existing infrastructure to be able to sort of approach this.
Yeah, I mean, I think, I've actually I've tried to compare medicine and medical care to the airline industry, and I think there are pluses and minuses to that. It's just a little bit very difficult to have this analogy, just because in medicine the human body is so complex. The clinical decision making is really not easy always. You sometimes have to make decisions based on what actually happens to a patient, but it's just not always easy. There are trade-offs in medicine more than the airline industry. There's no absolute. So I do think we can learn from the airline industry. There's no question about that, and I think we should. But I just don't think it's that simple.
Fantastic. So I just want to finish by sort of highlighting one of the things that you mentioned in the article, the need for in the trenches physicians to get involved. This is not experts in errors and so forth. It's everybody needs to be involved in this discussion and doing it based on the facts and the complexity of the world that we live in. So it just remains, unfortunately, for me to thank you, Chadi, for joining me for an outstanding paper. I think really important piece that has generated a lot of discussion, appropriately so, and making us all sort of contribute in a more thoughtful way to medical errors and improving the business of medicine.
Thank you so much, Nick. I really appreciate your interest, and I hope your listeners appreciate the conversation we had. Thank you so much.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at Dr. Nick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.